коллеги, рад всех очень видеть. Я думаю, что мы начнем нашу работу. Представляться, наверное, не будем, потому что все друг друга уже хорошо знают и уже, в принципе, как такая вот небольшая рабочая группа, которая друг друга хорошо уже понимает с полуслова. Поэтому я предлагаю, Алексей Израилевич, мы договорились, что вы два слова скажете, а потом уже начинает, наверное, Юрген. Да. Хорошо.
Good evening or good morning, dear colleagues. Today we will start our discussion, and I don't think that we need to introduce each other. We already know each other very well, and we will continue to our discussion, and Professor Mazos will give us quick introduction.
Добрый день еще раз, уважаемые коллеги. Я рад всех видеть, рад, что мы снова собрались. Спасибо большое профессору Марголису, который дал нам совет, как нужно всех собрать, чтобы все пришли. Спасибо, Леонид Борисович.
Thank you very much for everyone joining us today, and especially Professor Margolis and Professor Liederman.
И сегодня мы находимся в периоде нашего обсуждения, что уже, наверное, мы почти все знаем про COVID-19. У нас уже прошла волна этой инфекции, мы уже ее лечим. И, наверное, сегодня первый раз за много месяцев нашей общей работы мы попробуем вернуться к теме ВИЧ-инфекции. Чуть-чуть, но к теме ВИЧ-инфекции, которой за все это время мы ни разу не, собственно, вот обращались.
So today we will continue to discuss COVID-19. We already investigated it in different aspects, and we already treat our patient. And in most of the countries, we see a decrease in COVID-19 patients. And today we will try to switch to another topic. It's HIV, and discuss several aspects of this disease.
И я рад приветствовать сегодня впервые присоединившихся к нашему обсуждению коллег из Дальнего Востока, с юга России, из Сибири я вижу целую команду, которая нас слушает. Здравствуйте, уважаемые коллеги из Новосибирска. Я вижу нашего коллегу с севера Кавказского федерального округа. Приветствую вас. Но все, так сказать, там остальные, как я понимаю... А где Майкл? Я вот Майкла не вижу. Майкла еще не вижу. Ну,
он должен был быть, да?
Да.
Да, попробуем позвонить.
Вот. Итак, значит, пожалуйста, давайте мы начнем наше, так сказать, обсуждение. Еще раз большое спасибо всем, что нашли возможность сегодня к нам присоединиться. Нас ждет интересный разговор. Мы договорились, что начнет его профессор Рокштро своим, так сказать, докладом, который будет переводить тему ковида чуть-чуть в ВИЧ-инфекцию.
Today, several other regions from Russia join us. It's Far East, Siberia, and the south of Russia. Dear colleagues, we are gladly welcome you in this discussion. And we will start we will give a word first to Professor Rockstra, so he will give us introduction and switch topic from COVID-19 to HIV.
И прошу прощения, я не представил еще одного сегодня тоже впервые присоединившегося нашего участника, но вы его знаете. Это Александр Милерзанов, который работает в физтехе, с которым мы работали вместе на Ассамблее здоровья столицы и слышали уникальную работу, которую он ведет, и, собственно, его там институт тоже. Ну, поехали.
So, and I forgot about important speaker of today is Alexander Milerzanov. He had really great discussion at Moscow Assembly this year.
Юрген?
Please.
Okay. Let me share my screen here. All right. Добрый день. It's my pleasure to give you a very brief introduction on HIV and COVID-19 co-infection. Are there different risks for infection and clinical outcome? This summarizes my conflict of interest. And really, the first case reports are listed here. So there were 3 case series, one with 5, one with 33, and then also a small number of patients from China, which were the first to address the issue of COVID-19 in patients with HIV. And this is taken from the very first case series of 5 patients from Barcelona in Spain. And you can see that all of these patients were either male or transgender. Most of them were MSM. And you can see that they were on various antiviral regimens. Some included TAF, and some included abacavir. And there was one patient with no treatment at all. And you see some of the clinical findings on admission here, which are pretty standard, I'd say, except that they had a lot of lymphopenia as well, which is typical for COVID-19 infection. And then in the end, none of the patients died, although one was admitted to the intensive care unit. So following these first initial 5 cases, the Spanish colleagues were sort of under the impression that although they had seen very many cases of COVID with a high mortality rate, they just had the impression that people living with HIV were not at the same increased risk of acquiring COVID-19 or of progressing to acute respiratory distress syndrome because they had so few patients who got very sick. And so they sort of postulated that for reasons at that time unknown, it appeared that their risk may be even lower than that of the general population. And that was really some of the first kind of rumors which made its way. But one of the issues, obviously, is when you talk about HIV and COVID-19 and other populations, you always have to be very careful because you also have to look at the rate of comorbidities and age distribution and so forth. And obviously, from 5 patients, you could say only so much. The second paper in print was a case series from Germany with 33 individuals. And the first thing you will see here is in contrast to the Spanish paper where they just described 5 patients is that in this somewhat larger case series, the mortality was 3 of 33. So first of all, that would be at least around somewhat near 10%. So clearly that's much higher than the overall mortality rate we saw. And that tells you how difficult it is to judge on a case series because case series can be misinforming. And depending on who you have in there, in this case, there was one patient who was 82 years old. There was one patient with only around 50 CD4 counts, so some very sick patients in this cohort as well. But it does tell you that at least in that cohort, there were patients with HIV who got COVID-19 and died as well. Although the majority of patients had mild to moderate disease presentation. But again, the hospitalization rate was not very different, if at all a little bit higher than that was seen in Germany otherwise. And there was a high number of patients who were on TDF or TAF. And one of the deaths was on a patient who has received TDF FTC prior to infection. So at least this would signal that there's no 100% protection through TDF, and we'll come to that in a little bit more detail in a minute. Now, subsequently, there have been 8, if not more, presentations, again, of 2 up to over 100 patients with HIV and COVID-19, trying to assess sort of, are there differences in the clinical features? Is there difference in the rate of infection in that patient population, which obviously in cohort analysis is always difficult to assume. And there are really 3 studies I just want to briefly show because most of the studies show there's really no big difference. This is also a study which was just published in Lancet HIV, which suggests there's no significant difference in outcome between HIV infected and non-HIV infected COVID patients. But this study had a nice analysis depending on CD4 count, because you could at least speculate whether patients who have a low CD4 count are more prone to advanced disease. And you can see indeed here that patients who were critically ill with COVID-19 and HIV were more represented in the less than 200 CD4 count strata. As you can see here, none of the patients got critically ill in the above 500 CD4 count strata. So there's at least some evidence suggesting that with lower CD4 count, you may be at a higher risk for more advanced disease or more respiratory disease progression. Then there's one of the first American studies coming from New York, where obviously there was a high number of people infected with COVID-19, and obviously there are a lot of men who have sex with men in New York, and a lot of them have HIV. Interestingly, in this study with 88 subjects with HIV and COVID-19, there was no difference in the adverse outcome associated with HIV infection for hospitalized COVID-19 patients compared to demographically similar patient groups. So this was a study very much in tone of pretty many of the other smaller studies suggesting there's really no big difference, which is important because obviously in clinical in the clinical setting, you have a lot of patients asking, am I at an increased risk with HIV? Now, today, there was a study at the BIVA conference, so that's the British HIV Association, which is taking place currently as a virtual conference, and they had the first ever presentation of their outcomes from the UK people living with HIV database. And what they saw was a more frequent intensive care unit admission and ventilation, and also an increased mortality rate of 1.49 after adjustments for factors including age and comorbidities. So this is one of the first cohort studies which actually suggests there may be a less favorable outcome. So we're moving from the Spanish initial 5 patients and general impression that it may be more, or take a less progressive course, to there is no difference in outcome from New York, to the British colleagues saying there may be even a little bit higher mortality rate in HIV patients. And then there was last week a presentation which was made at a press conference in South Africa. This is from the Cape Town group, looking at the chances of dying from COVID-19 for different risk factors. They included 12,987 patients. I couldn't find out exactly how many HIV patients are in there, but remember that the prevalence for HIV in South Africa is among the highest in the world. So you can easily presume that there's a substantial amount of HIV patients, probably the largest group which has been looked at so far. And most interestingly, in this cohort analysis, again, HIV positive patients had a 2.7-fold higher risk of dying from COVID-19. So indeed, being HIV co-infected was unfavorable. So this is the second cohort study suggesting that there may be actually a negative impact in this setting of HIV co-infection. There was interestingly no difference by viral suppression. So whether people were on antiviral therapy or not made no difference in the outcome, and that's at least of interest to note. This slide from the Cape Town presentation, I think nicely puts sort of the risk into equation. So you can see the highest risk was really found in patients with comorbidities. So those who had diabetes, high blood pressure, and kidney disease were the ones most likely to die from COVID-19, but obviously HIV independently also contributed, and to a lesser extent, probably also TB. Now, since TB, but also diabetes is so much more prevalent in the African patient population, it's very difficult to compare these data to North American or Western European data. So I think really what we need is also a breakdown in the presence of comorbidities, obesity rate, and age for the various populations we look at. The study which probably caused the most discussion last week was a study which was published in the Annals of Internal Medicine and is from Spain, which looked at the incidence and severity of COVID-19 in HIV-positive patients receiving antiviral therapy. This is an effort from Julia de Amo, who's now working for the public health sector in Madrid. And what they found most interestingly was that they actually, in a large group of HIV-positive patients, 77,590, they identified, I think, around 250 who had a COVID-19 infection. And when they looked at the background NRTI, they found that patients who had TDF3TC were at less risk for COVID-19 diagnosis. So they were suggesting that actually TDF-FTC may have a protective effect in comparison to other NRTI backbones. Now, this has really initiated somewhat of a controversial discussion, because some people are saying, well, is TDF protective? But HIV-infected patients who remain on TDF-FTC today are, at least in the Western European sense, least likely to have many of the medical comorbidities associated with worse outcome in COVID-19. So saying that if you have TDF-FTC and have not been switched to TAF-FTC, that's most likely because you have are a young patient, have no significant comorbidities, whereas elderly patients who have renal or cardiovascular disease are now either all on TAF-FTC or just 3TC as a nuke backbone. So there may be a bias towards the patients who take TDF-FTC in Spain, or at least some of the other countries where access to TAF, just as well in the US, has increased substantially. There is some in vitro data suggesting that TDF-FTC may bind to SARS-CoV-2 protein. There is also some data suggesting that TDF as well as TAF may be inhibitors of the SARS-CoV-2 polymerase, and there's suggestion of antiviral efficacy in a recent study looking in the ferret model for antiviral agents and their efficacy against SARS-CoV-2 infection. So there is at least some in vitro evidence, but there is no in vivo evidence that this really works. So I think this remains under controversial discussion. And I'm sorry, I sort of missed that one point. Well, it doesn't matter. But I think what most people are saying is that it's very difficult, because you have to really see how is the distribution of comorbidities. For example, in the Spanish study, are people with TDF-FTC having less comorbidities? That data has not yet been released. Some of the studies, like the German one, show that people on TDF-FTC who also severely got sick and some died, that this is not 100% protection. So I think there's a lot of data going back and forth, and what I really think calls for is to create larger cohorts and address these questions again. I've showed you before that lopinavir, so other antivirals which have been discussed, includes protease inhibitors, and just taking this as a signature trial, which was published in the New England Journal, showing no benefit of boosted lopinavir for treating COVID-19, at least not severe cases. So I think we're still out there to have more convincing evidence that HIV-specific antivirals are of use in this setting. Our EX-BIVA statement so far has always said that most case series suggest there's no evidence for a higher COVID-19 infection rate or different disease course. I think this is becoming a little bit more difficult to judge, as we now have two cohorts saying there is a higher mortality risk. The other cohorts suggest it is sort of associated with the same outcome. And then there's the one Spanish study now suggesting that there may be some protection for those patients who are on TDF. So we have a very mixed literature data set at this point. I think what we can clearly say from all cohorts is that age, male sex, and additional comorbidities such as diabetes matter significantly and are the main drivers of increased mortality risk. We do believe that patients who have a normal CD4 count and suppressed viral load are not at an increased risk of serious illness. But we should remember that in all the studies, patients with HIV tend to have more comorbidities at younger age than HIV negative counterparts. And so clearly this is something to watch out for. It has to be assumed that immune suppression indicated by a low CD4 count or not receiving antiviral treatment may also have an increased risk for more severe disease presentation. And I showed you the one graphic from one of the case series suggesting that this is indeed the case. So we want to highlight that for patients with low CD4 counts and who experience a CD4 decline, that it's important to remember to initiate opportunistic infection prophylaxis, and the guidelines have corresponding recommendations. Smoking seems to be a risk factor of respiratory infections, so smoking cessation should be encouraged, and clearly because of the detrimental outcome of added bacteria infections, clearly pneumococcal vaccinations and also influenza vaccinations should be kept up to date in these patients. And then I'll just finish with the logo from EX, which says every action counts. So that's my presentation here. Thank you.
Thank you.
Большое вам спасибо, Йорген. Сейчас перейдем, наверное, все там на английский, как я понимаю, но очень полезно, потому что мы помним, что сначала почему-то считалось, что больные ВИЧ-инфекцией не должны болеть ковидом, потом пришла там информация о том, что или они, так сказать, болеют меньше. Потом выяснилось и в СМИ Майкл, приведи Майкл, привет. А сейчас выяснилось, что в больные, которые курят, не, так сказать, больные, то есть люди, которые курят, они там легче переносят ковид, да, то есть много, так сказать, фантазий, поэтому такие исследования, конечно, важны, нужны, но я передаю слово для, так сказать, там обсуждения, уважаемые коллеги.
Thank you, Professor Rockshore, for the presentation. So now we know that there is a discrepancy between the information from the beginning of pandemic, when we thought that HIV was a protective factor of COVID-19, and now we have new data that opposite this point of view. And the same about the smoking. So a lot of studies showed that smoking is a protective factor of COVID-19. And now we are going to discuss further this presentation, and we were glad to hear your opinion.
Jürgen, ausgezeichnet. That was really an excellent presentation. I learned a lot, and you really brought me up to date on a very timely outline of risks. Have there been any population studies that have determined, it certainly seems as though when someone's hospitalized, there's lack of clarity about outcome, and it may even be worse if they are HIV positive and hospitalized. Do we know anything about risk of acquisition of infection in the general population? I ask because there was a cross-sectional study from the Northwell group in New York that found of all of their patients who were hospitalized, 0.8% were known to be HIV positive, but in the New York City census, 1.3% were identified as HIV positive. I can't make much out of those differences. I don't know if that means anything at all, but have there been any larger studies in Europe where people actually keep track of everybody who gets healthcare? We don't do that in the States very well.
Yeah, so I don't think that we have really good information on these differences, but I think what I've learned is that if you have 5 or 8 or 6 patients, you tend to sort of take the story of these 5 or 6 and say the course is worse or better. But what it tells us is you just can't judge from your own 5 patients. I think we all have to wait for larger cohort data. And you know, it's very complicated because the African patients are always very different. I'm sure they have different levels of antiviral treatment success. They have the TB complication. They have much higher rates of diabetes. So we're talking of complete different patient populations. And that's where it gets, I think, very problematic. And I think it was kind of interesting because the BIVA study was just released. And since then on Twitter, there's been like a real Twitter war between the New York colleagues who have really seen no difference in the outcome. But again, this can all be depending on which kind of patient population you're seeing. And are you seeing a younger patient population, or are you seeing a longer in care patient population? So it's very dependent. And I think currently, I know the New York data would suggest there may be a somewhat lower risk of acquiring, and that would go very well with the Spanish data suggesting that TDF has a protective effect, which they didn't see with TAF. But then TAF is given to patients who have renal insufficiency. So it's going to be a sicker crowd of people. And so obviously the people are saying you can't judge unless you know the comorbidity and obesity rate for these patients. And I completely agree. I think you need a more complex data, but in this let's publish as fast as possible with the highest impact point battle, you will also see that not everyone has robust complete data sets upon submission. Needless to say, some are not even peer reviewed, and that makes it, I think, very complicated. So I think we have to be very careful in leaning towards one or the other. I think we now have data in 3 directions: protective in some studies, non-protective in other studies, better outcome, worse outcome, or no difference. And that's tells you that we're really not much smarter than when the epidemic started.
Yeah, that's great. Thank you.
Jürgen, thank you very much. May I ask a question? Dr. Marcus. So Jürgen, first of all, thank you very much for updating. I think you gave an exhaustive presentation. And with some kind of regret, I see that those of us who study HIV for many years have another big field in front of us to start to investigate. We thought that the number of fields narrow with the progress of now it's suddenly, unfortunately, expanded.
Sure.
And of course, I think that we're in the beginning of this part, and as you rightly, I think, pointed on the controversy of the study, because in the future, when we go on, unfortunately, we have to go on, we should divide this investigation, as Michael said, for probability of being infected and for probability of the severity of the disease and probabilities of little outcome. Because first of all, I think we don't know all comorbidities of these people. And also we don't know the state, which I now refer to Michael, of immune activation. As many things boil down to immune activation. And we know about HIV, the role of immune activation. But of course, for SARS-CoV-2, we don't know whether immune activation in people higher immune activated, it's more probability of infection, more probability of severe disease, more probability of death, or less. Because as you will know, HIV also upregulates, for example, cytokines in significant way. It's not quite a storm, but something similar on the law. Whether this storm is added to the storm which SARS-CoV-2 triggers, then, and if they come together, then you can expect the probability at the late stage of disease to be of a lethal outcome would increase. On the other side, people who are infected with HIV may fight, unfortunately unsuccessful with this virus, with the immune system. So it's something akin of some people, which we haven't tested, say that vaccination against other disease, like polio, may help people who are infected because they're already prepared for infection. So in the future, of course, we need to stratify, as you correctly said, these studies for probability of being infected, probability of severe disease, probability of lethal outcome, depending on when they have been infected with HIV, 20 years ago, and so they developed some atherosclerosis or whatever, or two weeks ago, a month ago. That was also different. And finally, I agree 100% with you that you can't, unfortunately, with HIV, compare people with Africa with people who live in Europe. And it's not racial difference, but the difference is in public health, where we know in Africa, there are so many other diseases which come with HIV or other infections, while in Europe, there are fewer. So we should focus, I think, on this, which you basically repeat what your outcome in part. Thank you.
If I may add a small comment on the excellent talk, I came across the study, I don't remember truly speaking, was it Chinese or American, but it was very interesting because it showed on a post-mortem autopsy, it showed that 30% of people who died from COVID, they had mycoplasma, 30% would have flu, and 40% sexually transmitted diseases, which brings us, I believe, to the point that immunological status of our patient, of COVID or HIV patient, should be investigated much closer, because definitely they are susceptible for a lot of different types of infections. Thank you.
Professor Jürgen, thank you for your nice talk. I just would like to add some comments about your ideas about worsening prognosis of these infected people. I think that it's very good that we have not so obvious worsening effect. At least it's not that evident that we have worsening. I think it's a good thing, and especially it's a good thing that we still have a chance to see effect of anti-HIV drugs. I think both these points are very good, and I think that we need to study this both effects, because HIV is obviously life-threatening, but very long infection, and person live with this through for many years. And I think that we need to see what would happen if COVID would, you know, stay with us for a long time. And now it seems more and more obvious that we will see that this virus will stay in population. And I think we need to follow this virus, at least because it's on adaptational stage. So we see that virus will change, and how these changes will change interaction with HIV and HIV immunity. I think this also very interesting effect, because HIV had a lot of time to adopt itself for human population, and with SARS-CoV, it's only beginning. And I think we need to monitor what will happen in the future because of virus evolution on human population. What do you think about this coevolution processes?
Yeah, so I would completely agree. I think we have to follow the patients, and since there is a change in the immune system through HIV, this patient population may react differently one way or the other. And I think what we need are sub-studies looking at immune markers and immune activation. Is that change in the setting of HIV co-infection? We actually try to do that in the HIV patients we have. We did all kind of functional studies, just like we did in the old days with HIV and hepatitis C, and found that there are differences in NK cells and function and clearance of infection. And so that you could at least think that things are different. But we only have 6 HIV patients with COVID-19 infection because we don't have any COVID-19 infections in Germany on a large scale. So our problem is we have limitations by numbers, but maybe you can all solve that.
Thank you.
We have the same problems as you.
Yeah, I would like also, it's very good review and provide a lot of information from different countries. In China, I did not hear any strong signal, either negative or positive for the co-infection, either negative impact or positive impact. In such a case, it looks like this is not no acute problems arise from the co-infection. So that also giving us the opportunity to study it carefully. I would think that the is maybe not so useful, since each of the individual study with the embedded limitations for either study design, number of patients, and and also the analysis. With our reviewer mentioned fast publication, and with the new culture, I would think it might be good to suggest to WHO, UNA, they have some study group and to collect all the data and reanalyze this data and to get some more precise and more clear picture, because these two viruses are going to be together for a very long time. It's just the beginning. We have the opportunity to catch it at the early stage and to provide a clear solution for this very important infectious disease.
Yeah, so I completely agree. I think there are three things I want to say. The one is you're right. There are three. I think there are three Chinese publications on HIV and COVID, and none showed a worst case. And I would say that if you take all 12 publications together, you would say the majority says we at least don't need to worry. So I would also agree that it's not going to be a state of emergency. The second thing is that even in the UK study, it's still a very low number of infected people. So the problem is that if you have a very low number, 3 patients with an unfavorable course can already drive your hazard ratio in a certain way. And the increases in mortality also in the UK are not huge. So I think that's one thing it's fair to say. I think what Michael said around what do we know about the risk of certain populations, I think that's really, for me, would be key to find out, is there a protective effect of an antiviral or not? And obviously one of the groups you would be thinking of is the PrEP cohorts, because the PrEP cohorts are taking just TDF FTC, and you wonder whether there is a difference in their risk for acquiring COVID-19 versus populations which are not taking PrEP. The problem is that we have very little population data where we can compare different groups, which I think would make perfect sense, because the problem, if you look at patient groups, is that there are specific reasons why you give certain antivirals to certain people, and that already may have an impact because younger people per se may be at lower risk. And those are the healthy ones, and the healthy ones may get TDF, and the sicker ones, which are per se maybe at a higher risk, are taking other drugs. So there's a lot of bias in these cohort analysis, and the idea of bringing this all together under the leadership of an institution or WHO or UNAIDS, I think is a good one. In Europe, there is an organization called NEAT, which is the Network for Clinical Trials, and they have created the so-called HIV dashboard, which they send to all the different centers and countries which participate in NEAT studies, and have collected hundreds of people now with HIV and COVID-19, and are now following up with a more detailed questionnaire, because I think if you look at all the cohorts, one doesn't have the comorbidity data, one doesn't have the smoking data, one hasn't a CD4 count, and some don't know the nadir, some don't know how long the HIV infection already is there. And I think all this data should be collected in order to get more definite conclusions. And I think in the end, only cohort collaborations will be able to answer this adequately at this point.
So it certainly sounds as though if there are risks among persons with HIV, they're not dramatically increased, and they're probably not dramatically decreased. In terms of determinants for acquisition of infection, this bit is unknown. And I think cohort studies, as Jürgen and Heming suggest, are going to be very, very valuable. It would seem to me that in the United States and Russia, who have not yet managed to control this epidemic adequately, both of us are not doing well. We need to focus on a couple of things. One is getting population behavior changes such that transmission is brought to as low a level as possible. And second, to learn how best to treat people who are sick and prevent serious morbidity in that fraction of individuals who are at risk for it. And I think that's what we should be doing in the States. And I think, in my opinion, that's what you should be doing in Russia as well. I think that's where our energies need to be.
Yeah, Mike, I absolutely agree with you. And as Jürgen pointed, we need to go from case studies to some cohort studies. And fortunately, it cannot be done in Germany, fortunately.
Yeah,
but it can be done in the United States, somewhat probably less and less in China, easily in the United States, can be in Russia, and easily in Brazil, where Michael and me have good, nice colleagues who can join us. And I have some maybe unrealistic suggestion, but maybe as science is based on replicates of data, repetition of studies, only many studies which repeat each other and confirm each other are accepted as a final scientific truth. And I know that Dr. Mazurs has a very powerful bioinformatic team. Russia is traditionally good in mathematics and sequential and bioinformatic following. So why not, and Dr. Mazos, take initiative in having this, our international committee, maybe join somebody else from Brazil, and collect published data, like exactly what Jürgen has done in Europe, collect published data in different journals, including archives. And it's possible to ask this team not only what they publish, but the primary data. Most studies require to give primary data unless somebody refuses, and you know what follows this refusal, you just to take away paper from Lancet. So, and maybe it's up to Dr. Mazurs. We can make a kind of bioinformatic team, including us, to analyze this data, to sort them out about comorbidities, infection, outcome of treatment, different treatment. And for the beginning, to make some table, maybe it will be helpful at least for us. And even somebody is doing this in Europe or in anywhere place, it's an obstacle. Repeating the studies is a bread of science in my mind.
Is it realistic to put together a collaborative clinical trials group in Russia, specifically in Moscow, where I know you've had lots and lots of cases to study interventions? Of
course, for Dr. Mazurs, but I emphasize that my suggestion is restricted to statistical analysis, not necessarily independent clinical trials. But about clinical trials, Dr. Mazurs can answer.
Thank you very much for your very constructive comments. And I want to introduce for you Alexander Milerzanov, who is Dean of Medical Faculty of Moscow Physical Technical University. And he wants to discuss about mathematic models of COVID infection process. Thank you. Please.
You're on mute.
Саша, вас не слышно. Звук включи.
Yeah, just 1 second. Okay, done. Okay, can you see my screen?
Yes.
So thank you for an opportunity to talk in front of such a noble audience. And we have really good teams. It's not only Moscow Institute of Physics and Technology, but also we work jointly with St. Petersburg State University and Moscow State University, which are pretty much 3 best universities of Russia, at least top at ratings. So here in this talk, I'm not going to talk about bioinformatics. This is different team, but I just mentioned that we have one of the best teams. We work together with the Federal Agency for Biomedical Studies. We have one department there, and another department we have in Georgia Tech and Atlanta. So we have a sort of a joint unit which can solve, and so far been successfully solving different problems in terms of bioinformatics. Now in this present talk, I'm going to speak more about pure math, and my sincere apologies from the very beginning, because I'm physician, I'm not mathematician. So there would be some things which I will not be able to explain without my colleagues. So sorry for that. So anyways, we were, last couple of months, we were discussing mainly an opportunities for prognosis and an opportunity to make different models. And we know that modeling business is quite difficult. Even in States, as far as I know, there are 24 models, and seems like new ones are going to be launched in nearest future. So there is no way we make a perfect model that would encounter all the specifics of a human being, of cities, of villages, of countries, and so on and so forth. So therefore, I would start with a quote from Emergency Handbook, where we can see the diseases where a single case is is counted as the danger for pandemic subsequences. And you see there is no COVID over there. And I believe that that should be changed probably, because now we know that any new infection is dangerous for pandemic, and COVID is a very good case for other infections to come, and unfortunately that's the future where we should be prepared to. Now, what do we have from WHO international data? There are several parameters, several indicators, to define virus outcomes, problems to deal with virus. And I'm not going to read the slide. You can see it, I hope. So the only thing that by impact, they mean the number of beds, from general number of beds in hospital that are devoted to COVID patients. And that's how they define it. By they, I mean WHO, yeah. Excuse me, World Healthcare Organization. And here underneath the screen, you can see the ratio of hospital admissions, which was done for influenza. And it might be true as well for COVID patients. And here we can see the ratio, where it means to have that infection has extraordinary impact. So for COVID, I believe we're somewhere around this 52.5 hospital admissions. Now, we have very good Chinese data. And here you can see the whole table, which is taken from 45 cities. And in this format, unfortunately, I cannot show you the whole slide, but you can see it online from this article. You can see it underneath. But the difference between Chinese cities was sometimes more than 3 sigma, if we talk about the distribution. So it was, statistics was totally different, even between Chinese cities, which are, you know, more or less have the same structure, same population, and so on and so forth. So what I'm trying to say, that it's extremely difficult to make a model that would describe everything, I mean, the disease impact on international level or even on national level, because difference is really huge even between cities of one very well organized country. Now on the next slide, you can see the map of population density all over the world. And naturally, we can expect that if we take, I don't know, Russia or Canada, the way people interact and the behavioral behavioral pattern will be much more different from, let's say, Southeast Asia or India, where the population is extremely dense. So there are several means that we are trying to evaluate that supposedly help to fight the pandemic situation with COVID. So masks. You know that there are a lot of studies, and unfortunately, we work only with open sources data. From this data, now we see that there is a question about the permanent use of masks by general public. We know that, yes, it works, and I'll show you later how it works to back the quarantine services, I should say, but there are questions about that. Now, social distancing. Again, reasonable to a certain extent. And later you'll see from statistics what we're talking about. And also ban on gathering. We have closed down business and educational facilities, and we were able to control the pandemic in this sense, but yet there is public transportation, there is subway, and unfortunately there is no way to close down everything just from not even ethic or economical point of view, but just from a point of view of humanity, to make people totally locked in their houses, in the apartments or whatever, that would probably bring much more problems than the situation what we have now. So that's why I believe it was really difficult to expect from government to close down totally everything. Now, I have to make some sort of disclaimer probably for the model that I'm going to introduce to you. First of all, there are several discrepancies. And for example, COVID hospitals admitted patients is not equal to COVID confirmed patients, because we know that it's not the same. Sometimes we admit patients with a difficult condition, with high temperature, with even pneumonia signs, but yet they have not confirmed COVID, either because of the problems with the testing or because they don't have COVID and have pneumonia and even CT picture of lungs, which is not COVID. Now, the second issue, different tests have different reliability. So far, we have bought several tests from different countries, and they all sort of different. And sometimes we can't really put our trust on tests, especially if they were not certified, if they were just brought by, I don't know, relatives, friends, and so on, from other countries, I mean. The other thing is this pandemic really took us by surprise. So tests sometimes were used not correctly because personnel were not sometimes properly taught to do that. Again, because everything was happening too fast. Now, pneumonia diagnosis based on CT scan, we know that it sort of goes against classic medicine, classic healthcare point of view. And yet we have to admit that we need more studies to see the correlation between the CT scan picture and confirmation by lab tests. Because at the moment, it seems that it's still questionable. It has to be investigated much deeper. Now, the next thing is patients with COVID who stayed home and were not even calculated and counted for the numbers, because some of the people are afraid to go to hospital, afraid to call ambulance, and so on and so forth. And these people, they stayed home at best case, and the worst case, they would still come outside, and that's a real problem for the infection spread. And last thing, we don't have data on penetration of social restriction rules. Meaning that even, I don't know about all cities, but even in Moscow, we know that there were cases then police were stopping cars and taking away, I may say, people who were known that they had confirmed COVID, and yet they decided to go around. So there is no way we can calculate these people in our model. Okay, and now we're coming to a model. First of all, we use this basic model, and here we come somewhat to mathematical part of it. So please don't be hard on me in this case. So there is a basic model that were extended by our dear friend Elena Gubar from St. Petersburg University. They made the extended scale, and where they calculated all people and possible scenario. And they used it, I should say, sold it actually to Italian government, and they use it for now. And it seems to be relatively accurate. but again, as accurate as model can be if we try to calculate all factors, which is difficult. And now we are trying also to improve this model, and we have made a new model for Moscow, fine-tuned model. I'm sorry, some of it is in Russian because I didn't have enough time to translate it into English. But we took data from open sources and created several coefficients for social restrictions and for quarantine index. And there are two major means to work with pandemic situation. First and most important is to work with confirmed patients. And second thing is to work with with general public, I should say. And we made the scale where we can actually see and make the prognosis with retrospective analysis of the previous data, how the situation would change in Moscow if we consider different levels of quarantine and different levels of social distancing. And we have two parameters. One basic, which goes for just for retrospective analysis, and another one prognostic for the future development of pandemic. And excuse me. So we came to the following points. Major thing is high-level quarantine. And in Moscow, in the peak of pandemic, it was actually 0.08, which is quite good, which means it was relatively effective. And as long as quarantine kept strong, other social restrictions were less important, and major role of these social restrictions were to back up the timing between the moment when patient gets sick and moment when he or she gets hospitalized. So here we can see the model. Even if we see, you can see the descending curve here, and yet, even when pandemic situation gets better, yet if we just stop all the quarantine the measures, then pandemic comes back to the ascending path. And this is quite sad because it tells us that we have to be extremely cautious until we really have the situation comes down almost to zero level. And now we made this model in June for the analysis for data from May. And here you can see how the situation changes if we change the quarantine measurements. I'm sorry, quarantine measures, right? And social restrictions, you can see here, yes, they somewhat important, but the difference is not that huge as the difference if quarantine is not taken seriously. This is the difference. I don't know if you can see my cursor, but this is the huge difference on the red lines once we stop using quarantine measures. Now, there is a place for discussion, obviously, because our mathematicians, they made 14 OD system, which is for just simple physician is, I'm just unable to understand it, but they said that they tried to use it for to calculate, to count all possible factors. So once we have real data, like from all the points where we need it, we can make as precise model as modeling can be precise at all. But the whole idea was to create the constructor, and we did it as a matter of fact. So we can hypothesize on different impacts on the pandemic situation. So now we have this constructor where we can put different factors, SC, what if, what would change if we do such or such a thing. Now, we obviously need more data. And in terms of bioinformatics and in terms of clinical data and so on and so forth. We badly need it. And once we have it, I'm sure our team would be able to make the really good models. And last but not leasting, therapeutic protocols. It's still under development. My friend, who is a professor in Moscow State University, and he's head of COVID Consilium, they created their own protocol, and it seems that it works quite well because they have mortality about 0.8%, which is, at least in Russia, as far as I know, one of the best, or maybe the best ratio. And they came back to glucocorticoid. They used, there is the whole protocol, but again, it's in Russian, but I believe it will be translated into English. Seems to be extremely useful. But again, I can't stress it enough, we need more data. Now the conclusion. From our models, we see that major impact is timing. Timing of isolation of people with confirmed COVID and clinical symptoms. Now we have 2.66 days between person gets sick and he or she gets hospitalized. And this is crucial. Once we can get it, I should even say nail it down to 1 day, we will not have the pandemic problem. That I believe so. The other way, the other thing, it's difficult to make it, but nevertheless, that's the major goal. Now, social restrictions, they're supportive. They're very important for these 2.66 days while the sick person, person is still on streets. That's why social distancing is still really important. Now, we need highly specific tests, because the problem is not just to, when we are getting this answer, yes, there is COVID, or no, there is no COVID, it's not enough, because it might be false negative. We need specific tests to see that if person feels sick, it might be flu, it might be whatever other infection. We need to know the type of infection, because if we don't know the type of infection, it yet can be COVID that we just haven't detected. And that, I believe, it's quite important. Now, tests should be readily available, naturally, and that's probably major thing to keep the pandemic situation down. Now, naturally, we need new antiviral drugs, and we know that we have 2 new drugs for that, and they have to be used on the very onset of the disease, and here we come back again to this 2.66 days. Once it's used in the very beginning, now have the study that in 5 days we don't see virus in humans who were treated from the first day. And last but not least thing is immunomodulation. That's what works. Now we know that it's extremely important with all the cytokine storm, so-called, but this is something which needs a lot of investigation. Again, there is no enough data. Luckily, we have first relatively successful protocols, but yet it needs to be investigated. Thank you very much. And
thank you very much. Very good presentation. Alexander, please, what is your opinion about second wave?
I see it not as much as second wave, as more like we have this analogy with earthquake, with when every second stroke is much less than the first one. We believe that we are going this way, and hopefully within the next several months, we come down to basic level.
Dear colleagues, please, your questions.
Alexander, that was really fascinating, and I have no real expertise in modeling, but you've come up with some recommendations for public health issues. And I wanted to ask you what you would think about sentinel surveillance, which is still not being done here, and I don't know that it's being done there. And by that, I mean picking regional centers, say, for example, hospital urgent care centers, emergency rooms, and without, irrespective of symptoms, testing for the presence of virus, with the idea that you may be able to identify occasional both symptomatic as well as asymptomatic infections in the general population, with the limitation of exactly how many people you could test. Do you think that's practicable in Russia? Do you think that's practicable in the US?
Thank you, Michael, for a very good question. Well, I believe that it makes sense, considering that tests, I mean, price for the test gets lower and lower. So economically, a burden should be not too bad. And considering that each patient with COVID gets another at least 3 patients sick, well, potentially, I believe that total testing makes sense.
I've encouraged as much in early March, but there was one that we didn't have the tests. We didn't have the test, and the tests that we had were defective in the US at least. And there was just no interest in doing such a thing here.
Well, that's a pity, because I believe this is something what works, because this 2.66 days, I keep saying it, but it's really crucial. And as a matter of fact, like for any disease, earlier we get it, earlier we get rid of it. So we're really into, and my ideal vision would be to have these tests readily available in all outpatients, clinics, hospitals, everywhere. And I would actually test all people who come for with any symptoms.
Right.
I mean, in terms of, not only in terms of respiratory disease, but any symptoms.
Absolutely. It has to, I agree entirely. It needs to include any people who come for whatever reason. And I was suggesting that this be placed in regional emergency rooms. So if somebody comes in with a broken leg or anything, everyone gets tested. And maybe this should be as broad as you propose to all facilities that provide healthcare. That would be incredibly pricey.
I can add. So.
It depends. Yeah, it's probably pricey, but it's still worth it if we have a broad pattern of pathogens.
Yeah.
And then we have awareness, and we all know that prevention is cheaper than treatment.
Yes, I think the German story why there are so few sick people is basically because people who were asymptomatic or had no symptoms at all were tested because they had risk exposure and were isolated immediately upon the result. And I completely agree that as soon as you know your result and you can isolate people, you're going to have much more impact on the further spread of the epidemic. We now have one state, Bavaria, which you all know has its own, used to have a king, so they have their own rules for that reason. And they now have free testing for anybody. So you don't have to have symptoms. If you want a COVID-19 test, you can get it for free in Bavaria, anywhere. And so this is also going to allow to see, so if you have like everywhere testing available with no cost, is that going to change the spread of disease versus more restricted settings where you predominantly test people who have a risk exposure or symptoms? So we will also see different testing strategies in Germany from different states, and I think that might allow a little bit to see what the impact is of how that is. And I would agree that, particularly in certain, at least in certain vulnerable populations, like now a lot of home for the elderly, for example, in Germany now have regular weekly screening of the people working there and so forth, which I find extremely recommendable, because there obviously are hot spots which develop very fast. There's also now screening in all places where meat products are being produced because of the ventilation systems and the cold temperature, which seems to facilitate a spread of disease. And so it also makes sense to think of special testing rhythms in people at high risk.
Jürgen, and a question like in Bavaria, what a percent of population of people who are not sick, who feel healthy, but have no reason to suspect that they have COVID, but still came voluntarily to be tested?
Yeah, so we don't know that yet, because obviously the other countries, the other states are saying you're crazy. What if all Bavarians go for a test every week, and who's going to pay for that? So I think there is a financial limitation, but I think certain people will not feel at risk. But I think it, you know, in the end of the day, you will always have some people who want to know whether they're negative or positive at this point. But the question is, how many people are you going to find out who didn't really have a risk but still have the infection? And can you by that isolate? And so if you in the end have no remaining infections and you really get everyone broadly tested and isolated, then probably your other measures of closing of schools or university is much less needed. So I think it's really broader testing allows opening of other things, which obviously economically is important. So we'll just have to see how much that costs overall and what impact the broader screening program is in comparison to more restricted or symptom-based.
Dear Jürgen, I have one more comment on your idea that broad testing is very good. What do you think about home-based testing? I mean, self-used telemedicine applications like applications on smartphones and so on. What do you think? Would it really improve?
Yeah, so I don't know, the test, you know, the swab, so it depends on what you're doing. If you're doing a direct PCR-based technique, then it's a nasal swab for now, and that is not so easy to self-administer because people need the shock moment of someone else doing it. Yeah. I don't know how good that really applies for a home testing.
At the point they realized how long should be swab taken.
Yeah, exactly.
There's some emerging data that saliva and amplification of sequences in saliva is pretty much as good as the nasal swab that results in a temporal lobe biopsy in some. So saliva might serve the purpose if validated for home testing.
Yeah, I mean, in all other kinds of areas like HIV, home testing have been an important addition to our testing armamentarium. So I wouldn't be against that at all. But you need a validated test, and all tests were equally good. And I think at least in the hospital management setting, the false negative tests or the issues of having the infection occur in different steps. And so first you have more positive samples in the upper part, and then later it's in the lower part. It can complicate things because you then, you know, de-isolate a patient, and then suddenly certain other probes are positive, and how to deal with that. And then there's still infections, onward transmissions in the hospital. So that's a very tricky part. So it's not so easy. I think the testing diagnostics are not as easy as with some other pathogens.
Yeah, you're absolutely right. And I think what's needed are validated tests.
Absolutely.
I think in principle, saliva can offer the opportunity to both look for viral sequences as well, much as we're doing third and fourth generation HIV tests, antibody sequences. So antibodies. So with a single test, in principle, you may be able to determine, again, once validated, whether someone has active infection ongoing or whether someone has antibody that's targeting the virus, representing the possibility of prior infection.
If saliva would be proven important, then you can develop a system like people measure genetics of their ancestors, just to put in a tube and send to reliable lab.
Right.
That's a combination between home testing and lab testing.
Right. Well, there are lateral flow assays that are out there. None of them have looked to be as good as other methods, but home pregnancy testing, which is reasonably reliable, uses a simple device. You know, I don't think we're there yet, but in principle, the technologies are out there.
Well, you know that now there are systems that for at least for urine analysis, you know that you can just take a strip, make a picture of it, and then using AI, you are getting the answer. Same thing we do for skin, and I believe that we are on the way to have it for viruses as well.
Yeah, but don't forget that the big difference is about pregnancy, HIV, that systemic disease you can check in the blood, which make average in the whole body, while in SARS-CoV-2, you have to locally take the sample, and it depends where to take it. It's more similar to biopsies, which if you do it blindly, you can take it from the tumor or from the healthy part in the old times. So I don't think that you can compare with pregnancy or even with HIV testing.
Well, I haven't said it. It's easy. I said we're going there.
Alexander, may I ask you more about this epidemic modeling? As you said that you started with Chinese data, that they are very good and shows that in different cities in China we had very different outcome. So this I have actually two questions. First question is, if we see so different outcomes, how do you think, what is the main factors we need to model to see to have better prediction power? That's the first question. And second, recently in Russian media, it was discussed that old models are bad because they're not taking into account behavior of different groups of these different groups of people, like they're not taking into account behavior of agent. So is your, I didn't get, is your model actually taking into account different behaviors between different groups of people? Could you please clarify these two questions?
Yeah, thank you. A very good question. First of all, we believe that probably behavioral pattern might be different. If we're talking generally, in terms of Chinese cities, well, probably our Professor Shah will tell us, but most probably behavioral patterns more or less close. So there must be other factors. Maybe it's density, maybe the development of public transportation, maybe even quality of the air. I don't know. There is something to investigate. That's for the first question. So the answer is yes. I mean, no.
Yeah, I think it's a very, very good study with the exercise of different model. I totally agree with that. Most important. So that's how to the time in the so we can
Professor Shah, I'm sorry, we can't hear you.
Yeah,
you
yeah.
keep breaking up.
Now, hear me.
Sorry, there is no sound.
No sound. Mute. You still cannot hear me.
We have some problem with volume and sounds.
Yes.
Volume is already very high.
It's probably his internet connection.
Yeah.
Yeah, the internet connection. I thought. You can hear, right? please continue.
Sorry, there's still no sound.
Yeah.
You,
Professor Shao, sorry, you're disconnecting and we couldn't hear you for a few minutes. No, we couldn't hear you, sorry.
Sorry.
Very beautiful picture. Please, Professor Shao, please repeat. Maybe.
Disconnect, you can join again for you.
Continue your
Sorry, we can't hear you. Okay, let me answer the second question.
Professor Shao, I'm sorry, could you just reconnect with us a little bit later? We have problems with your internet connection.
Okay, so meanwhile, for the second question, we have made the model with 14 different factors. And this is like constructor. So you can put anything there and we will calculate it as long as we have realistic data. So we can do different things. And once we work with it for a while and we fine tune it, then I believe we can use it pretty much for any infection. And then as a third step, we thought to put it on neural net to make it actually to count all links automatically. But yes, this is the plan.
Do you include virtual population? I mean, because in some models, people take like a virtual population of people living in different parts of the city using transportation system and so on. And this, based on this behavior, they try to improve performance of this system. Do you use something similar or not? No?
Again, we just made the constructor. Whatever you put there, we will calculate there. So it all depends on data source.
Okay. Okay. If someone will get you this virtual city, like Moscow, virtual Moscow city, so you will take it into account. Okay.
Yeah.
Okay, right?
I believe it should work. Again, I'm not mathematician, and when I see these 3 pages of formulas, I hope they're right and they work.
Yes.
I also have a question for your interesting modeling. So my understanding that you said that social distancing is less important, contributes less than a real quarantine, correct, right?
True.
Does it mean that in small cities where social distancing is easier to keep rather than in big cities like Moscow, New York, Beijing, where you have metro and etc., which you rightly said difficult to avoid. So the outcome will be very much different, even with the same % of population infected.
A good question. Well, you see, I think that there is different actually point. In Moscow, tests are readily available. So a person, when she or he feels sick, he goes, he tests himself. If it's positive, then it's one pattern. If it's negative, it's another pattern. In small city, I'm not sure that situation is such as good as in Moscow. So that's why probably social distancing will play much more important part than in Moscow, in a sense that, again, we have this almost 3 days when person is infecting other people. You see, and probably in province, there would be not 3 but 5 days. But as people have higher social distancing, maybe it will compensate for a while. But from our model, which was done for Moscow with data from Moscow, seems like quarantine plays maybe for 75%, something like that.
I think that's a reasonable conclusion. But my thing, you probably can test your model in addition, because in Moscow, you hardly can imagine you close all public transportation. But in small city, people can avoid public transportation. Without metro, they can walk from one corner of the city, of the town to another. So that factor can be taken from your model, and you can test what's the outcome without this.
Could be. We are open for suggestions and for new studies.
I just do it as a former mathematician who did some modeling in my life.
Alexander, what kind of data did you use? Talking about different tests, what kind of information you used about this sensitivity, specificity is just data from instructions?
Well, we have our partners, which is Camera Corporation, and they, for their own interests, have bought several tests from different companies, and they checked it.
Mm-hmm.
I cannot say which companies. First of all, it would be advertising. Second of all, well, I don't have the data on all tests. But I know that they made it, and if you are interested, I believe it's possible to ask them and get this this information. They are the ones who made this Afivir, this new antiviral agent.
Mm-hmm. We are in contact with them, actually. Maybe we have even tested some tests, I think, for them. I have one more question. Talking about these 2-3 days before a person gets results, whether infection is present or no, I have a question. Do you take into account this pre-symptomatic time? Because it's now evident that people start this distribution of infection earlier before infection setup. Did you take into account this time?
Yes, actually, these 2.6 days, it's not time between the taking tests and getting results. This is the time between patient gets sick and gets tested.
Yeah, but
that's where the major problem sits. That's what we were talking about with Michael. That's important to test people on a regular basis.
But do you add 2 days, 2-3 days before infection setup? I mean, before symptoms, because people become infectious before they develop symptoms.
Well, we have a certain coefficient. Well, the answer is yes. We take certain coefficients given to us by governmental authorities. So, and we place our calculations on these grounds. They're saying that general time for disease 8 days. So they consider that half of it may go asymptomatic.
Thank you.
Jimmy, you're back, so we're eager to hear what you tried to tell us.
Can you hear me now?
Yes.
Okay. Yeah, sorry. I'm seeing that the study is very, very good, very interesting. I totally agree with that the quarantine is most important. This is a technique of what the European used to control the plague in the ancient time. And I could share information with you. I mean, for China, Wuhan is made the first wave, the origin of the epidemic. They are the worst hit. More than 2/3 of the cases are only in this province. The rest of the province are mostly better controlled. The highest number is less than 2,000 for each province. I mean, 2,000, a province is about 50 million people in China. So it's a large country in the world. We have only Tibet has only one case. That is very unusual. It has only one case in one province, which is Tibet. We have in Beijing, we have just experienced not a natural second wave, but actually it's like a second wave. Since Beijing, we have no cases for almost, no internal cases for almost 2 months. And then on the 11th of June, we have one case. And up to now, we have 331 cases confirmed. So it's like a second wave. But yesterday, there are only 2 cases. They have down to 1 digital already for more than a week. How we achieved that? Because we do all the quarantine and the contact tracing. And we tested the testing. By yesterday evening, we totally test 10,050,000 people in just 2 weeks. So the highest testing day is about 1 million tests per day, the peak. So that is the highest confirmed cases is like 35 to 40 in 1 day. And now gradually down to 2 cases yesterday. This is through testing over 10 million people in about 10 days, 2 weeks.
And the people are confined.
Do you do pool testing? Do you pool or do you do individual tests for everybody?
We do pool testing, 5 samples, pool them together. Yeah.
5?
5, yeah.
5.
And even last time you told us about particular area in Beijing where this happened. So since then,
yes.
I think 16 cases. Since then, it spread to other part of Beijing or stayed in the same small region?
This is the same food market with vegetable, animal, fish. The largest market, the market supplies about 2/3 of Beijing's residents. The largest market maybe in the world. The Wuhan also started from a same market who are serving about 5 to 6 million people. This market serves about 11 million people. So they all started from the food market. But the last episode spread to all over the world. But this episode, only in Beijing, they have 1 kilometer, they catch about 50% of the cases, 331 cases. With half within 1 kilometer circle, 60% in 5 kilometer circle, 90% in 10 kilometer circle. If we see no more cases, it's 99%, it's a 15 kilometer circle around this market. Very early control. So it's like a exercise for the second wave.
Thank you very much for your comments. I want to introduce Alexey Mazus in new quality. Some weeks ago, Ministry of Healthcare of Russia Federation, Mikhail Murashko, signed order which give Alexei Mazos new powerful in HIV sphere, and now he has the same function as Emin Shao in China. Congratulations, Alexei.
Oh yeah, congratulations.
Thank you very much. Дорогие коллеги, значит, спасибо большое. На самом деле у нас, так сказать, там очередной чрезвычайно интересный, полезный диалог состоялся.
Thank you very much for your appreciation, and again, our meeting today was really important and useful for everyone.
Вообще, я сейчас подумал, что если мы вот все, что мы сделали за несколько месяцев последних собрать, то, Юрген, ты можешь сделать еще одно руководство.
So if we will put together all the discussions and topics, so Professor Rockster, you can write another book or article.
Мы продолжим, конечно, продолжим нашу работу. Она у нас получается очень здорово. И вот мы выкладываем на сайте Департамента здравоохранения определенные моменты нашей работы. Это пользуется очень большим интересом специалистов России.
So, we will continue our work, and I think that we are doing really great job. After our every webinar, we are collecting all the main topics and summarize them and put them on Moscow Healthcare Department website, and these materials are so popular.
Ну, зная, что вы все мои друзья меряете цифрами, то эту страницу сайта сегодня посетило более 2,5 миллионов просмотров, наверное, так.
The page of the website where all our data collected today visited more than 2.5 million people.
Еще раз большое спасибо за эту работу. Мы продолжим с именем, я думаю, отдельно сейчас переговорим. У нас есть, помимо научных интересов, еще дополнительный разговор по нашей совместной работе, скажем так.
And with Professor Shao, we have a specific discussion not only related to science, but for other topics as well.
Я надеюсь, что профессор Рокштер станет таким добрым нашим помощником в лечении больных, в консультации. Мы подумаем, какую форму этого диалога, возвращаясь к ВИЧ-инфекции, продолжим.
And with Professor Rockster, we hope that you help us to treat our patients, and we will try to figure out how to organize this.
Мне кажется, что к этому, безусловно, мы очень рассчитываем на совместную работу с профессором Лидерманом, чей бесценный вклад в ковид российский решением вопроса, как купировать цитотиновый шторм, был совершенно необыкновенным, нужным, и это спасло сотни людей в нашей стране.
And Professor Liberan, you gave us your knowledge and help us to treat more than 100 patients with cytokine storm. It's immense work. Thank you very much.
Профессор Марголис, который, конечно, является нашим уже, наверное, научным советником по целому ряду вопросов. Я очень надеюсь, что эта работа тоже у нас продолжится, найдет новые формы. А профессор Гущин, спасибо вам большое за те возможности работы с вашим институтом Камалея. Мы понимаем, что вы сейчас все заняты вакциной. Мы гордимся, что мы работаем вместе. Мы продолжим уже с нашими коллегами из физтеха, по-видимому, работу по моделям эпидемии. Мы очень рассчитываем, Александр, на вашу поддержку, на вот такое новое направление нашей работы. Спасибо большое.
So, and thank you very much, Professor Margolis. We really appreciate your scientific and other advice. And we thank you very much to all our colleagues from Gamaleya Institute. We know that you are really busy with vaccine development, but still we hope that we will continue our collaboration. And Professor Miller-Zanov, thank you very much for your presentation about modeling in COVID-19. And also we hope that we will continue our work.
И я очень рад, мне очень приятно видеть моих коллег Центра ВИЧ-инфекции в наших важнейших регионах страны. Они представляют округа, и в следующий раз к нам присоединятся еще коллеги. Мы возвращаемся к нормальной жизни работы и города, и наших медицинских учреждений, ну и к нашей профессии, потому что мы все-таки заняты ВИЧ-инфекцией.
And thank you all our colleagues from different HIV centers from all over Russia. We hope that other centers will join us in later conversation. In Moscow, we are returning to our normal life, to normal life in general and in normal life in clinics.
Еще раз спасибо. Я буду рад видеть вас в Москве, но с коллегами из России мы встретимся в среду. Вот. А вас очень ждем, дорогие друзья, в нашем городе, чтобы мы снова продолжили уже личное общение.
And after this epidemic ends, we hope that you will come to Russia, and we will be really glad to see you here.
Thank you.
Спасибо большое, коллеги. Я думаю, что нам уже пора завершать, и я думаю, что, может быть, по нашей традиции, так вот, я предлагаю, чтобы Леонид Борисович подвел итоги нашей сегодняшней встречи.
И дал совет.
Да.
Thank you.
Professor Margolis, you turned off your microphone.
Еще раз.
Sorry.
Okay.
For this honor, I think it was a very fruitful meeting, as well as a very fruitful the meetings before this, and it included both practical information, both on treatment, modeling, and the policy to somehow to decrease the infection. There was a great exchange of experience from China, Dr. Shao, from Russia, from the United States, and from Germany. So I think that it was very fruitful. It was multifactorial from different facets. I would like to thank my Moscow colleagues who organized it. And thank you very much to our hosts. And let's continue. I think that it's important, fruitful, and actually will be helpful to contain these epidemics. Thank you.
Огромное спасибо. Может быть, кто-то еще хочет высказаться?
Probably somebody else could say some conclusion words. Anybody wants?
Yeah, I would join Dr. Margolis to thank our Russian host for this very constructive and fruitful scientific exchange. I learned quite a lot. And congratulations to your voting for pass the new constitution. It's important for your nation.
Okay.
We have a new constitution and a new function of Mazus. It's very good idea. It's same process. Thank you very much for your time, for your very constructive speech, and see you later. Bye-bye.
See you later. Bye-bye.
Bye, thank you.